Hello again. This is Alan Winter with my colleague Charles Zelnick. Today we're going to talk about how the AI robot can assist us in the practice of medicine. We've talked about the workforce shortage.
We're not going to get any huge increase in providers who can stopgap this workforce shortage anytime soon. Currently, we're lacking 17,000 primary care providers across the country, and in certain areas, that's a lot worse. Particularly in my state of Maine, I think I told in a previous episode, my wife called for an appointment in October last, and they said, "Oh, great, we can get you in January." And in January of 2027, which was 15 months later. So very difficult to find a healthcare provider for primary care if you don't have one. And the projection is that this is going to get a lot worse, that in the next 10 years, we'll be lacking between 70 and 80,000 primary care providers in the country. So we're going to have to find ways to work around this to meet the needs of the population.
And certainly the elephant in the room is the workforce shortage. And again, until that's addressed by forces other than us, we can only make doctors as efficient as possible. And that's what today's discussion's about. The number of primary care doctors that are trained that remain in primary care practice 5 years later is only 25%. And that's because of unreasonably high patient volumes, time constraints, long work hours, and the rest of the problems listed here. Fear of liability, emotional strain, difficult work-life balance, administrative burden, loss of autonomy, the financial pressures and negative workplace culture, and the moral injury that's recently been imposed on physicians. Well, we can address the volume and time issues and reduce the long hours with some changes in workflow and some efficiency tools. And next week, we're going to talk about how to get rid of the administrative burden, which is simply a waste for everyone. So the old workflow, this is what we have today. The patient calls up, she talks to the receptionist. The receptionist says, yeah, we can get you an appointment with your doctor. It'll be a month or two, or as in
Or 15
Charles's
months.
wife's, 15 months. And then what do they tell you, Charles?
They said if you want to see a female physician, that's how long you got to wait.
What if I want to see somebody today?
Then you go to urgent care.
Yep, that's exactly right. And then that's fragmented care because half of it doesn't get back to your chart, especially if that urgent care is not in the same medical system. Or they might get you an appointment with a nurse practitioner, in 3 to 5 days? So finally, if the nurse practitioner finds anything complicated, she's got to send you to your doctor to your doctor, and that may be another month. So you're talking a lot of delays. And this is, I think, the biggest complaint about healthcare. Wouldn't you agree, Charles?
Yeah, I don't think anybody's happy with the delays in the current system and the lack of access.
So this is what I'd call a failed workflow. It doesn't work for anybody. And why this is continued is beyond belief. When we're going to show that the tools are available to fix it. And what are the results? Well, here's why doctors leave practice. The people that have chronic disease that they're taking care of would take 7 hours a day if under the present system of systems that are in place. About 2 hours for acute care. Just the preventive items, that's 1,000-page book just to list all the preventive items you need to do on all your patients. And then all the documentation that's required of electronic records, that's another 3 hours. And we're going to fix that today and next week. Charles, what do you think? Is that accurate? It comes from the AMA journal.
Yes, the preventive care particularly is a huge workload. If you try to hit all the boxes to hit your quality metrics that your administrators want you to hit, and the insurance companies want you to hit, it would take just years of your time, and you'd have no time left to take care of people who are sick.
So how can we help the primary care doctor?
So as we talked at a couple of the previous sessions, one of the things we talked about was AI triage tools that can make sure the patient gets the appropriate level of care. And this really requires that the AI be able to get enough data to safely tell which patient needs to go to urgent care today, which patient can wait for a more routine appointment, which patient can be seen by a mid-level or a nurse practitioner, or even sometimes the MA, or electronically with a televisit, and then which patients really need to be seen by the doctor. And smart screening tools can gather the data and fill in the chart by providing you some information that not only you need to triage the patient, but to actually get started with the visit. And then the new development of AI scribes allows us to take that information and put it in the chart, and will save some time in dictating, although we'll get to how much is actually saved in a little bit.
Okay, so we have to think about how we could change the workflow if we're going to do anything to improve the overload of 26 hours a day. Yogi Berra was famous for the comment, if you keep doing what you're doing, you're going to get what you got. And that's exactly right. So healthcare won't change unless we change the workflow. What could happen before the patient arrives at the clinic? What has to happen is the patient needs to call up, and if she calls and speaks to the receptionist could say, we need for you to go online and complete an interview, and then we'll decide what's the most efficient way to take care of you in the fastest possible time. So if the patient can just go online, then that puts them right into a rapid information flow. I know clinics that actually do this successfully for a number of years, but most clinics don't. They're in the old workflow. So the problem they'll say is, well, my patients can't use computers, or what else will they say when they call the receptionist? Charles?
Um, I think the big problem is that some systems are in place that collect data either by paper forms that you have to mail back in, or by simple questionnaires on the workflow. But then the offices often don't do a lot with that data. And I've had the experience seeing a new doctor where I fill all that in and mail it in. I do it on the web, and I come in for my appointment. My appointment is not, it's not triaged or organized based on what I've said, because nothing's done with that data. And then when I come in, the nurse sits down and goes through all the questions again and to put them in the EHR. So it's actually a duplicated workflow that doesn't really, I don't think really helps the nurse that much. But their data collection tools have not been connected with the office systems to the point where something is really done with that in most cases.
Oh, I would totally agree. I've had the same experience with one of the physicians I see. And I pointed out to him that the information he had on the paper form I filled out, the information I originally completed as a new patient, and the information in his EHR just collected by the nurse all had 3 different pieces of information in it, that when you put them all together, you actually knew the 3 things I would have had in my medical history. But if you looked at any one of them, he didn't have a complete view, and it was like the information was essentially wrong. So then the other problem is, what happens if the patient calls up the office and says they don't have access to a computer? What happens?
Well, with the AI systems now, you can divert the patient to a text system, and say, call this phone number and put in your birth date and identify yourself, or it can actually even have the AI scribe call the patient directly with the phone number they give the office, and go through the history by text message, or go through the history on their phone. Almost everybody has phones. Or the AI can actually call and speak to you in English or in your native language. I'm working at a free clinic where we have a lot of patients who are from Africa and from overseas, and some of the tools we use do speak the patient's language directly.
So that data can be collected and put into the EHR in a much better way to allow triage to occur. So this AI data gathering is really critical in this new workflow because the patients can be screened and then the nurse can look at that. I'm not sure that the smart tools of screening are ever going to be the level that they're going to do what the real nurse is going to do, just as we discussed in the Swedish model a few weeks ago. I think that's a good model where the nurses look at the data and then they make the call. They say what's going to happen. And what does that look like? Well,
I think it helps improve the trust in the system as well, that you keep a human in the loop to do your triage to the appropriate level here.
and if she keeps in mind these three models that we've talked about, the value healthcare, the network healthcare of chronic problems, and the solution healthcare that you really need a real diagnostician, then I can see this occurring where the nurse decides which do you have. And if you have a value healthcare problem, then she sends you to the robot doctor that may ask you some questions online, or as we just said, a voice response. And then the nurse looks at this output and makes a decision, may present it to the physician, or under protocol may simply prescribe the 3 days of maybe a urine antibiotic for a urinary tract infection. And this could be a real benefit to actual care, in the sense that the patient calls up and they're streamlined right to what they need without delay. The second thing the nurse can discern is the patient really needs to see the nurse practitioner to get a refill on their medicine. And this might be handled by the nurse practitioner and tell them to come in the next day or two, or however many days it's appropriate, the nurse can decide. Or the patient could be seen by telehealth. Sometimes when we do refills, and we'll talk about refills next week in more detail, is we would do them by telehealth, because everybody that called for a refill in my practice needed to be seen in some fashion, or data needed to be gathered. So these chronic diseases of network healthcare can be rapidly taken care of as well, without delays that currently we see in the workflow, where if you're going to see your regular physician, it may be months, whereas instead of scheduling appointments every 3 months to see your regular physician and filling up their schedule, we should have the schedule open so that the patients could get in to see the appropriate practitioner, either your doctor, if you've got a complication of those illnesses. Say your blood pressure has gone up because you've been taking it home and now suddenly gone up 20 points because you've been eating licorice. Well, you need to see your doctor to figure that out, or perhaps get in. But normally the network healthcare should be seen by the physician. I think the way you described it a couple of weeks ago. Don't you agree, Charles?
Yes, and as we talked about in the last session, if you're having abdominal pain, that's the day you really want to see your physician to get that diagnosis sorted out as part of solution healthcare. And by triaging things appropriately, and by having everybody operating at the top of their license, that hopefully frees up enough time that you can get a same-day appointment with your doctor when you're having a severe abdominal pain.
I don't think there's any question that could happen. We did it in my practice, and I think the open scheduling is really the answer. where everything is just in time. That's what every other industry uses, is just in time information. That's what we need to do in healthcare, not this traditional workflow that has been around for 100 years and now is completely outdated. So we know that this will work. And as a result, we could possibly divide up the patients calling that day into these three buckets, perhaps. 36% of the patients really have stuff we can handle fairly easily, I think. They have a medical question. They just have something that we could deal with quite simply if they could get in. If we don't see them, they're just going to get worse. It's like the asthmatic on Friday afternoon. If you don't get them the steroid inhaler refill or their other medications, they're going to be in the hospital by Sunday afternoon. So early treatment of these people can actually make the simple stuff be handled very quickly. And the same with the network chronic diseases. We could schedule them in the next week, and people would be happy to come in that period of time. And finally, like you said, we can see all the people with abdominal pain right now as they need to be seen, rather than sending them to the emergency room where nobody knows them. And if they get sicker tonight and they call me back, I'm not going to know necessarily what happened if they went to a different system's urgent care. Don't you agree, Charles?
I agree, and my experience was that my nurse, who was really good at doing this type of work without the AI, was spending hours and hours a day on the phone, whereas I could have used her help in other ways in the office to actually get the patients the care they need, rather than just talking on the phone all day, triaging this and then queuing it up for me to take care of.
So one of the ways this will happen is with the real-time AI scribe. As we talked about, the data would be in for the history. The AI scribe can record what's occurring in the visit, and by implementing a look back into the electronic health record, could create the visit in a pretty good format, so that even while the physician is finishing up and prescribing the right medication, the entire record could be finished. Has that been your experience, Charles?
Yeah, I'm a real big enthusiast for AI scribes. And in fact, if we look at adoption across the country, this has been one of the biggest things to come along for physicians in decades, I think. We're seeing steady adoption of this at a fairly rapid rate. Not every physician is comfortable with it yet, but I think as more and more see in action that we'll see wider adoption. My experience, I've used three different AI scribes, and they all work similarly. They allow me to put my phone down after I get the patient's permission to use the scribe. And then I just sit and look at the patient and make eye contact and say, what's going on? Tell me what's happening. And the patient can do that sort of rambling walk, like I showed it the last time, going from here and there, talking about their son, talking about their current abdominal pain, talking about their family history. And the AI scribe will write it all down and sort it out into a typical doctor note. Some of the scribe programs will actually connect what the patient's telling me to the medical literature, and we're seeing more and more development of scribes that are integrated with electronic health records, so they can actually propose orders, propose medications, and add things to the problem list, allergy lists in electronic health records, so that the physician doesn't have to do that. This is a huge advance. The research shows that one of the biggest benefits of this is decrease in burnout scores for physicians, as well as improvement in eye contact and in the patient-doctor connection. It does save a little bit of time, but only about 3 minutes per patient visit. Some of the reason we don't see a lot of time saving, I believe, is because you have to go back and read through what the AI scribe writes down to make sure it's correct. And there always are concerns about hallucinations, of course, with an AI, but additionally, sometimes there's just simple problems where it may write he instead of she because it doesn't recognize that the patient's female or male unless you tell it sometimes. Sometimes it may suggest additional diagnoses that really you're not working on, but it may misunderstand or take things out of context. So you do have to read through it and correct it, because at the end of the day, the physician is responsible for making sure that that information that goes into the chart is correct. So I don't think it saves a huge amount of time, but it's much faster for me to go through and read a note after I've seen a patient and correct it than it is for me to actually dictate the whole note, especially if it's a complicated problem or a patient with multiple complicated problems. Sometimes that could take me up to 20 minutes or more to dictate on a patient that only took me 30 minutes to see. So that's a huge time savings.
So we could look at the AI scribes work in real time if they were properly integrated, as I'm going to show in this video. Because what we're going to try to do now is sort of put it all together. I think we've talked a lot about technology and how it can really help us, but what does that really look like? And what our goal is going to have to be is to get to a place where a doctor can actually have an 8-hour day and it really makes sense. And here's what I think the AI can do. Clearly, we're still going to have complicated patients that have to be seen, that have multiple illnesses and are going to be seen in the office. Don't you agree, Charles? I mean, somebody with hypertension and they have symptoms that may suggest a stroke, they got to come in.
Right. With the shortage, I see the physician's job is going to be taking care of more complicated or sicker patients. So we really need all the help we can get when we're doing this kind of triage.
And then the acute care patients, if we cut them down with the AI triage tools and the screening, then and use of the nurses properly, we could probably get that care down significantly. Then finally, the preventive care is where we can really make an impact, because the AI scribe and agentic AI can actually look in the chart, see what the patient's missing, and then ask them if they've gone somewhere else to have their vaccine, or have they had their colonoscopy and maybe we didn't get the results. So I think that's an area where we can have a dramatic impact. Wouldn't you agree?
Yes, that's one of the things that takes me the longest now with the current electronic health record, is figuring out what's already been done and what needs to be done, just because not everything's connected in our healthcare system.
And that goes back to asking the patient in the original triage whether you had this and where was it done, because there's so much fragmentation in healthcare. So then the final box is we can reduce documentation in the inbox to less than an hour. I'm convinced. And we're going to talk about that next week, because that's a big headache for physicians. So this is fully possible in my opinion. So I'd like to show a little video of my office, and I didn't have all these things together, but we'll walk through it and see what it looked like. So the patient walks into my office and they've already registered online. This is a 20-year-old video. Then they come back, they have their vital signs taken, and notice the machine puts the vital signs right into the electronic record. We still have nurses entering the vital signs into the record rather than having it integrated directly. Obviously, our scale wasn't integrated, but then the patient goes back to the office. I come in, the patient has already entered their data. I can talk to them. I say, thank you for filling out the information. Then I look at it to sort of confirm what they said. And then I say, okay, tell me how this is bothering you. So I'm looking at the patient the whole time after having reviewed what they put in. So after I complete that, I advise them to get on the exam table, take off their clothes, and notice there's a few seconds here where I can take the data that they've put in and any additional data that I have gathered from them in that interview of additional questions I may have asked or changed the information that they entered. And then I examine them, complete that, sit back down. I can enter my physical exam very quickly while they're getting the clothes back on. And
Or
meanwhile,
the AI agent might enter this for you. Yeah.
yep, could enter it right to take the scribe directly, or it would be a good time for me to review what the AI scribe has suggested as far as looking back at the data. Now I have all the diagnoses done. I'm going to tell the patient what I'm going to do about it. And then I advise them I'm going to write a prescription. Now if it was a protocol, possibly the AI could recommend such as a refill, and then I'm going to tell the patient what's wrong, what I'm going to do about, suggest, answer their questions, and my eye contact on this visit is pretty good. As you can see, we can talk, and the visit becomes much better. I come out. Um, I've reviewed what the AI has done. This patient didn't have a computer, so I give them a copy of their visit note, and they're out the door. And you can see how this could really work. What do you think, Charles?
Well, I think we know it works because you've been doing it for 20 years with patient software that you've had. I think the potential to really buff this workflow up and make it even more helpful with AI tools is certainly there. And as you said, what I do now is I tell the patient I'm going to speak my examination as I go through it, and I say it'll be in some medical knowledge, but ask me any questions that you have, and I'll say the knee is swollen and there's crepitance under the patella, and as I do that, the AI scribe will just write that into the chart for me. So it saves me a lot of typing and a lot of data entry.
Yes, that's exactly what I was trying to demonstrate, even though I didn't have that at the time that video was taken. We can improve the workflow to actually make it more efficient for patients and be able to see them on the same day. And I think that's where that's where we have to go. And a number of years ago, I actually saw this in action in the UK. There was a physician in the UK that did this, and he was really well known. And I studied his office. How does he see 55 patients a day and go home at 5 p.m.? You got any ideas, Charles?
You had to move really quickly and be organized.
Well, exactly. And he basically did the workflow that we've talked about using the AI, only he had nurses to do it. And certainly we could have nurses. And what it resulted in is he would treat 20 of the patients that had minor complaints with e-visits, or just have the nurse call them up and give them a prescription or a recommendation for care and say, okay, you can come in tomorrow, the next day if you're not better. So he did about 40% of the patients that way. And then there were clearly 20% of the patients that he kind of needed to see. So either his nurse or he would discuss them, and one of them would then do the patient on telemedicine face to face, because that patient really did not need to have a physical exam associated with their symptoms. So again, everybody was treated the same day. There were no appointments prior to that day, and he was able to handle these people with chronic diseases in this fashion. And then finally, he had about a quarter of the patients that were actually pretty sick, and they may either have a complication of one of their chronic diseases, or they had a complaint, a symptom that was clearly a solution healthcare issue that required a physician to look at them, possibly order some tests, follow up, and it worked. So I think this idea that we projected is actually workable. It's been done before, and it was done, as I saw in the UK, with nurses. What do you think, Charles?
Your properly trained healthcare team is really key to be able to do this safely. So we need everybody working at the top of their licenses in the office. The RN should be doing RN stuff. They should be seeing patients by telemedicine and using protocols that are safe and effective and have been proven and tested. And the AI can certainly help with that, but you have to have that the human and the team member in the loop. But currently, we don't use everybody in the healthcare office at the top of their license. So being able to build the tools, build the workflows, build the protocols to do that is really important.
I totally agree. And I think what we've tried to do today is to suggest that we can improve the physician's efficiency. We can see patients a lot quicker, and they don't have to wait months in primary care. This idea that you see in health systems where the role of a receptionist pool is to schedule the expensive physicians out as far in the future as possible is just a failed workflow, and not using them to actually see uh, patients that are sick that day is a mistake. And we can fix that with these AI tools, just as we discussed. And even though there's a significant physician shortage, I think we can make inroads into that by having the tools that we've talked about, the AI scribe, get rid of the documentation, having the data put into the chart, so that the EHR is really a side effect of the visit, and the doctor's really not touching it much at all, except editing it. Would you not agree?
Yes, yes. And with the looming shortage we have, we really don't have a choice. We have to use the physicians that we have in the most efficient way possible, because with just no other choice. Otherwise, people are not going to be seen. So it's important to build the workflows and to build trustworthy AI systems that have been tested and validated, so that we can do this safely. And the effort should be to have the physician do what physicians need to do, and not to be focused on the billing or the financial incentives in the healthcare system.
Absolutely. I don't think a physician should ever have to be a money changer. I think
Right.
the idea that
We don't want to use the gains in efficiency to just make them work harder.
right, but administrative issues and clinician burnout are going to be our topic next week. So, Charles, do you have any parting comments?
Thanks for having me. I think it's all about the workflow, and the technology is certainly exciting, but how we implement it is the key.
Thank you again, Charles, and we'll see you again next week.
Thank you.
Bye.